welcome that you've received already from Amy and from Craig, and the thanks to all of you for coming on your weekend. As Craig mentioned, we really do learn so much from your questions, from conversation, and from the dialogue that we have together. It's my privilege to kick off the talks of the session with the 221 year in review, neuroendocrine research in individuals with pediatric hypothalamic and pituitary tumors. I'm going to include some adult data as well. I really enjoy giving the talk each year. I maintain now a folder on our lab's shared drive where we compile interesting papers over the course of the year. And as the talk approaches, I have to have the challenging job of culling down into only a few to share with you, which reminds me that throughout the year, if you find research or other findings that you think are of interest that I should share, of course, please send them my way. And here are disclosures for me as a speaker. Starting again with gratitude, really, Amy and the Raymond A. Wood Foundation for hosting this conference. As I mentioned, I won't go through the many people who contributed. We could spend the entire session on that. With respect to outline and special considerations, I'm focused on neuroendocrine studies because I'm an endocrinologist, of course. Certainly, this is not a comprehensive list. Our colleague from St. Jude's, Dr. Merchant, we're so grateful to have him speaking later. His team is prolific in what they publish, so I'm leaving most of that to him, although you'll see I am including some of their papers today, and please do share studies you find. All right, so the first such study is actually from Kristen Neal, who did her training at St. Jude and is now at CHOP, and she gave this talk to us about this study, and I was really interested to share it with you. So this study is focused on health-related quality of life in individuals who've had craniopharyngioma. I think that the research in this area, understanding quality of life in more detail, is really growing, and it's an area of focus that I'm happy that we have. This study included 78 individuals with craniopharyngioma after having undergone surgery, but before treatment with radiation, who were ages 6 to 20 years old. And the investigators examined various risk factors that they thought might contribute adversely to quality of life in individuals. They studied excess daytime sleepiness and found that 82% were affected by this, diabetes insipidus, around half of the cohort, and nearly 2/3, 59%, had the highest grade of hypothalamic involvement of the tumor. So the tumor involved the greatest extent of the hypothalamus on the measuring scale. They then tested individuals' executive function. Executive function refers to our ability to undertake mental processes that are important for planning, organizing, and strategizing. And then they assessed patient-relevant outcomes, health-related quality of life, both as reported by the patient themselves and as reported by the parent. And they constructed this model, and you can see all the different arrows, really, and the model could also be expanded from here because there's many other factors that the group didn't even have time to include, but that each of these factors interact and affect each other. And what they found was interesting to me, though not surprising. They found that first, diabetes insipidus predicted worse parent-reported quality of life in two different ways. One was directly. One imagines that this may be related to the burden of caring for diabetes insipidus, of managing it. And then also indirectly via effects on impaired executive function, which may reflect the extent of the damage that a tumor might have produced to lead to both diabetes insipidus and executive functioning problems. For me, the takeaway of this paper was the importance of individualized neurocognitive screening and intervention, and using the risk factors that are identified to help tailor prevention efforts in the care of our patients. Switching gears a little bit, still focused on craniopharyngioma, but better understanding of what happens and what causes stroke in this condition. This group examined 244 imaging scans in individuals who'd had craniopharyngioma that were obtained between 2007 and 2019 in a longitudinal observational cohort. Fortunately, this is an infrequent outcome in the treatment of individuals with craniopharyngioma, but of course it's a very important one. So it's important for us as practitioners and for patients to understand what risk factors may increase the incidence of stroke. So those risk factors they identified included the presence of hydrocephalus. Hydrocephalus literally means water on the brain or buildup of fluid in the brain prior to the operation. And perhaps intuitively, the more extensive the extent of surgical resection, that was also increased, associated with increased risk of stroke. So for me, the takeaway is that planning by our surgical colleagues and counseling efforts can take these risk factors into consideration in preparing patients and families for operations. The next study I'd like to highlight is focused on adult onset craniopharyngioma. I know we may have some pediatric families in the audience, but I know that Amy's also really focused on addressing the needs of folks with adult onset craniopharyngioma as well, a group that may have been less well studied historically, but fortunately now is getting more of the attention that it deserves. So this study focused on factors affecting metabolic outcomes in adult onset cranial. They included 45 adults who had undergone surgical treatment of adult onset craniopharyngioma. And they found that 76% were already overweight or obese at presentation. These are higher rates than we see typically in children. And 81% were overweight or obese at the last follow-up. Interesting to me as an endocrinologist, 22%, we got some movement of the slides, 22% had diabetes, type 2 diabetes at presentation, and 29% at last follow-up. Interestingly, weight gain was worse in those who'd had the lowest weight prior to the procedure, and that's illustrated here in this schematic. So they've divided the group into what the BMI category was prior to the operation. So folks who had normal weight, overweight, or obesity. And you can notice that in the individuals with obesity, for example, the weight preoperatively and the weight at the last follow-up was around similar. So the weight gain had occurred presumably prior to their operation. And in contrast, individuals who were normal weight experienced the largest weight gain. Not surprisingly, the presence of hormonal deficiencies, so pituitary hormone deficiencies, predicted weight gain. And the takeaway from my standpoint is that for many adults, weight gain has already occurred at the time of their presentation or will occur with their treatment. And that leads us, of course, to the conclusion that we've made before, which is better treatment options are needed, right, that don't produce some of these adverse outcomes. And we'll get to some of those options in just a moment. This paper I thought was also really interesting. It speaks to weight gain in childhood brain tumor survivors, but in a way that might be a little different than other studies have in the past. This group studied 661 childhood brain tumor survivors, but they focused particularly on individuals without craniopharyngioma and without pituitary tumors, so other tumors in the brain that may grow to involve the hypothalamus and pituitary, but not kind of pituitary focused tumors per se. And they found that rates of overweight and obesity were more than twice as high as compared to the general population. So their population of focus were aged 4 to 20, and rates of overweight and obesity were nearly double. They found risk factors for increased weight gain in these childhood brain tumor survivors. Those included high body mass index at the time of diagnosis. Low-grade glioma, that particular tumor type, was associated with higher rates of obesity, and then the presence of diabetes insipidus, also central precocious puberty, early development of puberty. All we might expect was associated with greater degrees of hypothalamic involvement in damage and increased weight gain. So the takeaway for me from this study is that the BMI increase in these individuals. So if the weight starts to increase in individuals, even if their primary tumor may not initially involve the hypothalamus and pituitary, may indicate to us as clinicians that hypothalamic pituitary surveillance or testing should be pursued because there may be hormonal deficiencies that require treatment as well. So as these cases highlight, when we think about potential complications of tumors or treatment, there's certainly a need for improvement. And I think that's going to be a theme throughout the day. This is one paper that really has been interesting and is kind of aligned with the theme of topics of adjunctive medical therapies or new ideas about new ways of treating tumors like craniopharyngioma. And the Raymond A. Wood Foundation presented a talk by Cassie Klein and colleagues about some of their work in this direction. that's moving forward. Here I'm presenting a particular case report that I think the group will find interesting. So this case was of a 37-year-old man who'd had a year of headache, vomiting, visual impairment, and sinus headaches. And we look back at his history, as a 10-year-old, he had come to attention for headaches, problems with growth, and was ultimately underwent 3 different operations for craniopharyngioma. And I have a note here, he didn't undergo molecular testing of the type that's often done on surgical specimens now to understand the molecular profiling, the different genetic mutations that may define the tumor. And of course, this didn't occur because this is a presentation of an adult case. And the gentleman presumably presented on the order of 20 to 30 years ago when these testing was much less routine. When he came to attention this time, though, he underwent a 4th surgery and was found to have craniopharyngioma with a BRAF mutation, a V600E mutation, a mutation that's been characterized before. And his symptoms improved in response to the surgery. However, 41 days later, he experienced rapid tumor regrowth. And there's a question here of what to do. And you see the title of the case report that suggests the approach that was taken, which is to use a chemotherapeutic agent called vemurafenib, a BRAF inhibitor. So I'm going to share from this case report what the experience was with this medication agent. So vemurafenib was used because the molecular profiling of the tumor suggested it might be effective. And the investigators found that this agent decreased the tumor size. And you can see that from these images. So these are pairs of images that were taken at different time points throughout the patient's course. So this was imaging before the 4th operation. This was imaging intraoperatively. And then this was, we talked about how the tumor got worse relatively shortly after the operation, before the vemurafenib treatment, and then 49 days post-treatment. And we don't have to be neuroradiologists to appreciate the pretty impressive improvement in tumor size here. So vemurafenib permitted shrinkage that allowed completion of control with surgery and radiation. So really made this treatment more achievable. Every new treatment, though, that gets considered, of course, can potentially come with side effects. For this particular medication, elevation in the liver enzymes, joint and muscle pains, and light sensitivity complicated the course, but it still seemed to really offer this gentleman an option that might not have otherwise been present. The takeaways for me are the value of the molecular characterization, the genetic testing that is becoming more and more routine by our neuro-oncology colleagues to really understand the differences in tumors and to understand whether or not there are medication therapies that could be part of the repertoire. And it's also, of course, important to understand the side effects of these newer therapies, many of which can include some risk for endocrine consequences, although the risks for endocrine problems are much less than can occur from the tumor themselves. So having more options are valuable, and I'm really excited to see what more will come in this space. Switching gears to hypothalamic obesity, a topic that I know is really important to the group and will be the focus of a few of our different breakout sessions this afternoon. So I'm going to only spend a short time on it here, but there's more to come for sure in the course of the session. So one thing to highlight with respect to resources, I had the opportunity recently, along with colleagues, including Jennifer Abuzahab, who's going to be talking more about hypothalamic obesity this afternoon in the breakout, Ashley Shoemaker and Christian Roth, to update the National Organization for Rare Disorders information page on hypothalamic obesity. We hope this provides more information for patients, families, practitioners, anyone who finds it of interest. I'm highlighting here some more information that we like to offer to folks who may or may not be familiar with this word, with hypothalamic obesity. What do we mean by that? I imagine this group is more familiar than most, but for anyone who isn't, the way we've come to think about it, and this is an adapted set of criteria from Bob Lustig out at UCSF. Of course, there's a presence of a brain tumor or other injury that affects the hypothalamus, that important area of the brain that regulates metabolism. Also, that in individuals who are affected, we often see an excess rate of weight gain that's related in time to either the diagnosis or the treatment of the tumor or injury. And additional evidence in support of a diagnosis of hypothalamic obesity, although it's not required, would be one other endocrine hormone dysfunction, because of course the hypothalamus and pituitary affect a lot of endocrine hormones. So when there's more endocrine hormone dysfunction, that's additional evidence of important damage to the hypothalamus. So that resource is something that you may wish to check out, and we welcome your feedback if you choose to. Switching gears to therapy, last year at this session, Christian Roth presented his really exciting study on a class of medications called GLP-1 receptor agonists in individuals with hypothalamic obesity. I'm really excited to report that in the interval since Christian gave his talk last year and now, a newer form of GLP-1 receptor agonist, Christian presented on exenatide. What I'm mentioning here is an agent called liraglutide. Liraglutide has been approved at the 3 milligram daily injection dose for individuals with obesity. That's all comers, so quote unquote common obesity, but certainly open to potentially individuals with hypothalamic obesity as well, for ages 12 years and older. Other GLP-1 receptor agonists, including exenatide, but also a lower dose of liraglutide, are already also FDA approved in the United States for individuals 12 years and older who have type 2 diabetes. And this is really encouraging to us as clinicians because it means we have more options to offer folks with hypothalamic obesity. My clinical experience, we have Christian's terrific study in exenatide in individuals with hypothalamic obesity that demonstrated some modest benefit with respect to decreasing the amount of fat in the body on average. Liraglutide overall has been found to be more helpful for weight loss than exenatide was even. And our clinical experience I've shown a little bit here. Some individuals with hypothalamic obesity respond quite well, others not at all. Many are able to tolerate the side effects that I'll review in a moment, but others less well. This top panel is one example of an individual who, with hypothalamic obesity, who experienced quite a strong response. So you can see this is a growth chart with body mass index on the y-axis. You're probably used to seeing these in clinic. So this is body mass index at the time that liraglutide was initiated. And this individual experienced around a 20% weight loss, such that the body mass index had gone from above the 97th percentile to around the 90th percentile. And then this person developed gallbladder disease, which is common in individuals experiencing weight loss and had to have gallbladder removed. But this individual was quite pleased with the response. And in contrast, there's someone else whose body mass index chart is shown here, who started liraglutide, didn't have any particular side effects from it, but also didn't seem to experience much in the way of benefit. I'll mention that clinically, some colleagues have also observed that in addition to weight loss, there are individuals who experience decrease in appetite and decrease in cravings in response to GLP-1. So I'm mindful as we discuss this issue that weight management is one goal, but management of excess appetite and cravings can be a really important outcome for others. So important to think about that in making treatment decisions. Side effects of this class of medication can include nausea, also less common, but they exist, risks for pancreatitis and gallbladder disease. And most vexing, to be honest, have been, at least for our American audience, and I'm not sure the experience abroad, but has been challenges with getting insurance approval, particularly with some insurance plans that have these as plan exclusions. Jen Abuzahab is going to share her experience with these medicines later today in a breakout session. So a nice opportunity to discuss these in more detail. Semaglutide is yet a next generation GLP-1 receptor agonist. I'm sharing this information. It's not specific to hypothalamic obesity, but mainly because I'm just really excited about how efficacious this has been shown to be in individuals with common obesity. So semaglutide at the 2.4 milligram weekly injection dose led to, on average, and these are the data in otherwise healthy adults, led to a 14.9% weight loss after 68 weeks. That worked out to on the average of like 30 pounds or so. This is shown in kind of with the data cut two different ways, but the graphs show similar things. This is how much as a percent from the start, the weight decreased over time. And this is the placebo condition where there was a very modest weight loss. And then this is the semaglutide condition that showed the nearly 15% weight loss that you saw. So on the basis of these data, semaglutide, that weekly injection, was approved for otherwise healthy adults with obesity this past summer. And actually, it's been so popular, there's a shortage now currently, as I understand from our adult colleagues, and when we try to get it for the young adult patients for whom we care. Similar side effects to other GLP-1 receptor agonists. There is an ongoing clinical trial in otherwise healthy adolescents with obesity, so stay tuned because an adolescent approval for this medication would really be exciting as another option. I always look before this talk to see whether or not there are clinical trials recruiting for individuals with hypothalamic obesity. I mentioned here that these are simply listings, not my endorsements. So anyone is welcome to go search in the US, clinicaltrials.gov. If folks are not familiar, this is the website where we are required to register our clinical trials. So anyone looking for research opportunities, either related to hypothalamic obesity or to other conditions, is welcome to go and look and see what's out there. Currently recruiting, we have setmelanotide, which is a melanocortin-4 receptor agonist, and also I have seen as pending, so not recruiting yet, psilocybin with an indication of hyperphagia. So those are two, but these change day to day and may have even changed since I put this talk together. So you're welcome to look for your interest as well. Switching gears to another comorbidity of treatment of metabolic importance, more and more we're turning our interest to the heart, to potential cardiac effects, both in the short term and the long term, of childhood brain tumor survivors. So we know that individuals, in particular with craniopharyngioma, can experience an excess risk of lifetime cardiovascular complications and risk. So this group, knowing that, examined 36 individuals who'd had craniopharyngioma and used echocardiography. Folks may be familiar that is an ultrasound technique for examining the heart. And they looked for evidence of what's called cardiac remodeling, so changes in the size and structure of the heart that can indicate increased risk for future cardiac disease. And they found that mostly cardiac remodeling was observed in relationship to individuals who had increased body mass index and size. So that's shown in this schematic here, where body mass index, SDS, refers to relative degree of excess weight. And then the intraventricular septal diameter, that's one parameter that we see on the echocardiogram that refers to the size of the heart. They also seem to find in this study, which was new to me, that male sex and the use of sex steroids may indicate increased risk for cardiac remodeling. Now, cardiac remodeling on its own is not sufficient to cause cardiovascular disease. And one challenge in studying this phenomenon is that one would have to look over a very long time to really understand which individuals ultimately develop cardiovascular disease and complications. But it's interesting to me because I think this particular area hasn't been one that's been focused on quite as much, and I think deserves the attention. So takeaway from my standpoint as a clinician is to continue to examine cardiac health, including, for example, if folks are starting medications that include cardiac risk, to do an EKG and have a low threshold to refer to our cardiology colleagues for evaluation before undertaking some of those interventions. So switching gears again, I'm going to keep going through my tour of articles from the year, briefly focusing on the adrenal gland. So this has been something that's important for us to know as clinicians, and then for families as well to think about. There are new, better cortisol assays that have been introduced this year. So for folks who are unfamiliar, cortisol is the hormone that's made by the adrenal gland, helps our bodies day to day maintain enough energy, appetite, and then in times of physiologic stress, so illness, accident, injury, cortisol is what helps fight those stresses, in particular keeping up blood sugar and keeping up blood pressure. So cortisol production is controlled by the hypothalamic pituitary hormone, ACTH, in individuals with hypothalamic pituitary brain tumors can have adrenal insufficiency because of damage to that hormone producing system. So we use adrenal stimulation testing techniques to diagnose individuals with adrenal insufficiency, or we simply measure morning cortisol levels to understand the degree of risk. And I go through this background for you because the newer, better ways of testing cortisol that are being adopted yield slightly different results than previous assays. So this is shown in the schematic here. So on the left is the older historic assays, and on the right, the newer assays, in particular, the mass spectrometry and assay types that we use most often. Oops. And you all would say, like, these are results of tests like black, light gray, and darker gray that are done during stimulation. And if you stand back and squint, right, like these levels look pretty darn similar to these. Certainly the direction is similar. But if you take, for example, this peak, right, that goes to like the mid 20s, and this peak, which goes to around 18 or 19, those are different. And these are just the different assays applied to the same specimens. So it ends up that many hospitals are using different thresholds to define what's an adequate response to testing, different thresholds to diagnose adrenal insufficiency. So for folks who are in the process of undergoing those evaluations, or who do not have adrenal insufficiency currently, but are who being evaluated for that, it behooves you to think, as we are as clinicians, about which cortisol levels and assays are being used when stimulation tests are being done. So when you compare today's results to results from a year ago, 2 years ago, 3 years ago, to bear in mind that a new assay may be used. Also important on the adrenal front, I presented on this last year, but we're gaining more experience with it. So I'm presenting again because some of our patients also were unfamiliar. So this is the availability of hydrocortisone sprinkles. Hydrocortisone is a synthetic form of cortisol that's used for adrenal replacement or for stress dosing. And the smallest tablet strength is in 5 milligram tablets. You can break it in half if you're pretty good at that and get to a 2.5 milligram dose. But for our littlest patients, our youngest patients, the dose we might want to give might be smaller or in smaller increments than that 2.5 milligrams. And you say, why don't you use liquid medication? Because that's what we often use for little ones. Unfortunately, liquid hydrocortisone outside the hospital, where our pharmacists like formulate it and give it right away, has limited stability. So it doesn't hold up well in the refrigerator, for example. But more recently, these sprinkle formulations were approved down to 0.5 milligram increments. And you see they can be broken up and put into a little yogurt or applesauce and given that way. So for individuals who have smaller little ones at home, or for folks who find that they're sensitive and want to try kind of more smaller incremental dosing, this has been a nice option. Switching gears again to growth hormone. We've talked about the importance of growth hormone before, and one of our fellows, Julia Crowley, is actually studying growth hormone in pediatric brain tumor survivors, and we're hopeful next year to bring the results of some of her studies. Previous observational studies have shown that initiation of growth hormone in childhood for folks who are deficient may improve body mass index, fatigue, and emotional health over the course of their lives. And last year, I mentioned to you all, the FDA approved a weekly formulation of growth hormone, somapacitan, in adults. Of course, adults aren't growing anymore, right? So the approval, meaning the outcome that the study tested to show that the growth hormone worked in the adults, was decrease in truncal fat. That's fat around the midsection. So was focused on that metabolic benefit of growth hormone in individuals who are deficient. Recently, this past summer, the FDA approved, I'm not even going to try to say it, but lonapegsmatropin, which I guess I was successful at saying, which is a weekly growth hormone formulation in children who are at least 1 year of age and weigh 11.5 kilos, based on a study where they looked at height velocity, which is how well is a child growing in a weekly growth hormone formulation as compared to a daily growth hormone formulation. I'll show you those data in just a second. Importantly, this is the schematic that you see on the right is from a recent review article. Growth hormone has not been associated with recurrence of tumors, There's a theoretical risk, meaning we wonder, and that's illustrated here, growth hormone causes healthy tissue to grow. There's a theoretical concern, would it ever cause tumor tissue to grow? Would it ever increase the risk for recurrence? Fortunately, we have not observed that in longitudinal observational type studies. However, it's something that's important to bear in mind, and we always at CHOP initiate growth hormone in collaboration with our neuro-oncology colleagues. So a little more on the once weekly growth hormone formulation in pediatric study. This study included 161 treatment naive prepubertal children with growth hormone deficiency. Of note, this initial study did not include anyone with an intracranial tumor, so not direct evidence in folks who are likely watching of interest today. That I imagine is so that folks could have clarity with respect to side effects outside a population that may experience higher rates of complications from other problems. This was a non-inferiority trial, meaning they were just trying to show, does the long-acting form work about as well as the daily form? This is a schematic that shows molecularly how the growth hormone is altered so that it lasts longer in the body. And I'm showing you here the results. The main outcome was how quickly the child grew at 1 year of treatment. This schematic that I'm showing is the height Z-score change from the start of treatment. So you folks may hear in the clinic about what their height Z-score is. It might be lower than one might expect in individuals with growth hormone deficiency who haven't been treated, but it will increase over time as growth hormone is replaced. And so this compares how the weekly long-acting form as compared to the daily form increases height Z-score. And in this study, actually, the weekly form tended to perform a little bit better. There were no important safety differences. There were some differences in the IGF-1, that's the hormone we follow in response to growth hormone treatment that are helpful for us to understand as caregivers. We don't have more data on body composition, which I'm really interested in for this, but I think this will be coming around and be available soon. Insurance coverage is something that we're going to have to learn about because it is more expensive than the daily form, as we understand at the moment. So stay tuned as we gather experience on that. With respect to puberty, just a quick reminder, I spoke about central precocious puberty earlier. Individuals who have hypothalamic pituitary tumors can either have puberty that occurs too early as a result of the brain tumor, or that can occur too late or not at all. Both we can see. For individuals who have early puberty, we treat with a medication to slow the puberty down or stop it. Gonadotropin receptor hormone blocking agents. So there's a long-acting implant that's like the matchstick size. Suprelin is one example that goes kind of in the upper arm. That often is required to be placed under sedation or anesthesia. Some kids can do that as an office procedure, but more typically sedation or anesthesia is required. It has the benefit of being long-acting, so it lasts around a year or so. Also, some folks may have experience being treated with injections of these agents. They're intramuscular injections, meaning they're given kind of like a flu vaccine every 1 to 3 months. Recently, there was a 6-month formulation of the injectin approved. And importantly, instead of an IM injection, meaning an injection into the muscle, this is subcutaneous. So similar to folks who are on growth hormone, a much more shallow and less painful injection. So there was a study done to demonstrate that this form works well, that could be an alternative to folks who need puberty suppression. What the investigators were looking for was evidence of both the hormones of puberty being suppressed by the medicine, as well as the physical examination changes, right? So in girls, breast development, in boys, testicular enlargement, penile enlargement, and the study found really good evidence of efficacy in this 6-month study, or the 6-month injectable study, and showed overall it was safe and well tolerated. So to me as a clinician, we can consider this option for pubertal suppression, particularly in folks who may not wish to pursue either more frequent monthly injection or Suprelin, one of the implants. Unfortunately, insurance coverage for this is a consideration as well, as it is for everything. Turning our attention to diabetes insipidus and the little bit of time we have remaining, This is a slide I'm putting up not to go through in detail, but just mainly to celebrate. This is the clinical pathway that we have for peri-procedural management of diabetes insipidus at CHOP. Other institutions have pathways as well. Seattle Children's, my colleague Christian Roth, they have a nice one. I'm really happy about this because we know that around the time of pituitary procedures, managing diabetes insipidus can be really challenging. This resource, along with Seattle's and others, are available on the web, and we hope will help our clinical colleagues really achieve more consistency in how we manage these patients. If you're curious at the approach that folks take to learn more, if you have diabetes insipidus or someone in your family does, we welcome your checking that out as well. Spending a few minutes on oxytocin, we could have a whole session on it, and Amy Wood actually put together such a session, which I would direct you to. It was really fantastic, but just a few slides. Oxytocin, as folks know, is another hormone that's produced in the hypothalamus. This paper came out this year in Pituitary. I thought was really interesting. They studied individuals, adults, who were undergoing transsphenoidal, so pituitary surgery, and they found there was increased excretion of oxytocin in the urine before the development of something called SIADH, syndrome of inappropriate antidiuretic hormone secretion. So taking a step back, many folks who've had pituitary surgery may have been counseled about the risk for the release of vasopressin or antidiuretic hormone, same thing, from the posterior pituitary. Diabetes insipidus is deficiency of vasopressin, and it happens that if there's damage to the posterior pituitary, all of that hormone kind of dumps out and leads to hyponatremia, low blood sodium levels. Sorry about that. Leads to low blood sodium levels. And what was really interesting is they found, and this is where they looked at oxytocin in the urine in individuals who developed hyponatremia versus those who didn't, that there was higher amounts of oxytocin that they secreted. So these authors found this interesting because we're always trying to predict in the hospital who's going to develop a complication with low blood sodium levels after pituitary surgery. And they wondered if measuring oxytocin in the urine might be one way. The other thing that I found interesting about this paper is that, you know, we talk about the theoretical risk of oxytocin deficiency in individuals who've undergone hypothalamic pituitary surgery. And the demonstration here that oxytocin behaves kind of like vasopressin in this way. In other words, it's released in the days following a procedure in a similar way to vasopressin might give us a clue as to understanding the dynamics of this hormone. So an interesting paper here. This group well knows that we recently wrapped up a study of intranasal oxytocin. I'm sharing the design, and I'm not going to share the main outcome yet. I want to make sure that that undergoes peer review before we share it, but hopefully that will be very, very soon. So I'm going to give you just a quick peek at the design and some information about the cohort. So this was our study of intranasal oxytocin. It was a double-blind placebo-controlled crossover trial. We included adolescents and young adults with hypothalamic obesity. A crossover trial, the schematic is shown here, means folks are randomized to get either oxytocin or placebo. And then after a washout, which meaning a time where you don't get anything, you switch to the other condition. We used weight-based dosing and measured weight. We focused a lot on safety. We also studied energy balance and social function. And we are submitting this manuscript imminently, so I hope to have more on that soon. But I did want to share, and I tried to restrict this to one slide. You can tell there's a lot to share. Just even some information that I learned in studying this terrific cohort. So we had 13 individuals enrolled, 9 of whom were children, so under 18, 4 of whom were prior to puberty onset. With respect to their oncologic diagnosis, most had craniopharyngioma, which we might expect in a study of hypothalamic obesity, and also, as expected, pituitary hormone deficiencies were common, including 9 individuals with diabetes insipidus. One thing I got to learn about and do in the course of this study was learn about grading hypothalamic injury from my colleague, Francisco Perez, also Christian Roth from Seattle Children's, who showed you last year a scoring system that they developed on the post-surgical MRI to assess the degree of hypothalamic damage that in their hands and in ours as well seems to associate with the degree of weight gain. So we were able to calculate those injury scores in our cohort and find that the average score was 5.5. So, or the median score was 5.5. The score goes on a scale from 0 to 7, where 7 indicates worse damage, which is similar to the scores they had in their trial. And I think this is helpful because as more and more trials are done, having ways to understand the differences between the cohorts that were included in different trials can be really valuable. Individuals had obesity, not surprising given the focus of the study. I was really curious to gain more experience with different tools for evaluating eating behavior and hyperphagia or hyperphagia excess appetite in individuals, and also collaborating with my colleague, Matt Hawking, who's a pediatric psychologist looking at family function. So we found eating behavior and using a validated questionnaire was really variable in this cohort, but on average, folks demonstrated similar disinhibition, so lack of kind of control and hunger, as otherwise healthy adolescents with quote unquote common obesity who also had a diagnosis of binge eating disorder. So the kind of prevalence of problematic eating behavior was similar to a cohort that carried this diagnosis. With respect to hyperphagia, again, I was struck by how variable the responses were in our cohort. On average, though, less than using a similar scoring system, a cohort with Prader-Willi syndrome, where folks are kind of often more uniform in their expression of their hyperphagia. There was some family function impairment noted, kind of similar to other cohorts of brain tumor survivors, which are with around a third with scores in the problematic range, meaning problematic family function, challenges at how the family operates for various reasons. So I hope in future to share more details about outcomes, but already I want to thank the participants in this study because we've learned so much from the characterization that are helping us take care of folks in clinic and in future. The last slide I have for you before we go to questions, COVID-19. So here is one case report that I mentioned because last year we weren't sure what was the experience going to be like in folks who developed COVID-19. So far, I'm overall reassured. COVID-19 seems to have similar effects as other childhood illnesses in folks with hypothalamic pituitary brain tumors, which is not to minimize its effects because we know, depending on the child, even routine childhood illnesses can unfortunately land them in the hospital, can make them really sick, but no different than others. In general, I'm just saying it out loud because we get this question often. We do recommend the COVID-19 vaccination to prevent that now vaccine preventable illness. Of course, if you're receiving treatment for your tumor, then reviewing the timing of this vaccination with oncology is really important. We don't recommend stress dosing just to start. We do use your usual criteria for stress dosing if fever, for example, or other symptoms develop. So this is our contact information. I see there's been some questions coming in through the chat. So we have some time left. I look forward to discussion.
Hey, Shana, can you hear me?
Yeah.
Okay, so we have a few, I'm going to start with some stress dosing, adrenal insufficiency cortisol questions. First question is, what is your opinion in stress dosing during emotional stress, like death in the family, tests in school? So that's the first part of the question. Second part is, does long-time use of Cortef affect other organs in the body?
Those are both such challenging and excellent questions. So with respect to the psychosocial stresses or like death in the family, those types of things, do you know, our endocrine textbooks will say that those may not be reasons to stress dose. What we learn in the textbook is this is like fever to 101, car accident, major operation. Over the course of time in my practice, I have heard from families who are adept at managing their condition, who find, and I think the questioner brought up like taking a test, right? Like that was a really stressful situation that they found that giving some extra hydrocortisone was helpful. And I would never minimize our patients' experience because truthfully, those folks know the best. I think how I have typically counseled my patients, and each circumstance is of course different, we want to avoid excess stress dosing, which is going to get to the questioners, the next part of their question, right? We want to avoid doing this all the time because life is stressful and we encounter stresses every day. And if we increase the dose all the time, which is not what they've asked, but if we did that, that would have side effects. I think also when folks choose to increase it somewhat, for example, I mean, we're in SAT season, so that's on my mind. Increasing it to a modest extent rather than kind of the full stress dosing may make sense. So talking through your experience with your endocrinologist and finding what works for you and some kind of compromise there is often, those are the conversations I'm having these days. And then the question is, what's the downside of too much Cortef over time? Amy? Yeah. So I kind of reframed the questioner's question of what's the downside. She said, or he said, what's the downside of Cortef? And I'm saying, what's the downside of too much Cortef? Because our goal as endocrinologists, right, for all of these hormones is to replace just what nature would give back if the pituitary were functioning appropriately. There are risks to too much supplementation, mood effects, excess weight gain, effects on bone, sleep, but too little can also leave folks vulnerable and unsafe, which is not a risk worth taking, also fatigued and nauseated. So striking that right balance is really important.
Does it affect other organs?
Oh, it can affect absolutely like every organ.
Yeah.
So if you look at an endocrine textbook and we say what parts of the body can be affected by cortisol, I would challenge us to find an organ that's not affected. So absolutely, the questioner's right about that.
I'm sorry. Yeah, I mean, I think the question was long-term Cortef, use of Cortef affect other organs, maybe more, in a negative way is probably the
question. Yeah, I think it could if the dose is too high. The ones we think about predominantly the liver, the bone, the brain, but really every organ could be vulnerable.
Would and another question, kind of just to back up to this, is can a patient receive too much hydrocortisone, which you said yes, which could cause other issues? Could it cause Cushing syndrome?
Yeah, well, so there's Cushing syndrome and Cushing's disease. The most common, one common problem we see as endocrinologists in the hospital is consequences of too much steroid use. Like for folks who take steroids for asthma, for example, or inflammatory conditions, they get doses of steroids that are 10 to 100 times more that we might give for daily replacement. And those folks definitely get side effects, including, and so we call that Cushing's disease when we have too much cortisol effect in the body. Cushing's syndrome is from a tumor that produces too much ACTH.
Great, thank you. And then
Cushing's syndrome is from too much of all of the hormone.
Okay, and then another is it recommended to have cortisol testing periodically for acquired adrenal insufficiency following a resection of a tumor? So maybe the question is more about ongoing testing of that.
Yeah, good question. So for folks in whom they were not initially diagnosed with adrenal insufficiency, but are determined to be at risk, yes. Because, and you talk about with your endocrinologist, like, is there a chance that could develop in future? For some people, it's true that it might. For folks in whom the diagnosis has been made, there isn't typically a role for repeat cortisol testing because, for example, if like the entire ACTH producing cells, if all of those are in the biohazard bin in the CHOP OR, then like they presumably are not coming back. So it's an important point from the questioner, like unlike thyroid hormone, for example, Dr. Bauer this afternoon will tell us, like, we measure these different types of thyroid levels to assess how well we're doing with replacement. We do not do that with cortisol. It's why dosing is so challenging. We dose according mostly to symptoms and according to the amount that we expect someone to need.
Okay. And then a question about daily dosing. So one is, how does one ensure daily dosing is effective and efficient with optimum results?
Optimum results. So all individualized is the first. We start with what the textbook typically recommends for central adrenal insufficiency, which would be 6 to 8 milligrams per meter squared per day. Meter squared refers to body surface area. I was trained to pursue adrenal replacement in a way that recapitulates the circadian rhythm of cortisol with a higher dose in the morning and then a more moderate dose in the afternoon. Cortisol levels are typically low or undetectable at midnight. So we try to recapitulate that pattern. Different people have different needs with respect to like when can they take the dose? Is twice a day, or some people do 3 times a day, like what's convenient, and then how do they feel throughout the day? What's their energy level? Are they having symptoms like nausea? To try to individualize that dosing, because that's where we start, but we certainly don't finish there.
And along the same lines,
Lots of adrenal questions, Amy.
yeah, so I'm trying to put them all together. So there's a question about night dosing. So what's optimal timing for evening hydrocortisone dosing? I heard about possible effects glucose tolerance, but I can also imagine sleep disturbances if taken too late.
Do you know, the questioner brings up an area of controversy in endocrinology practice. So there are some folks who do a bedtime dose of hydrocortisone, like towards bedtime, because and the thinking there is that cortisol levels naturally rise and increase, 4-ish, 5-ish a.m. and get to be their highest at 8 a.m. Well, nobody's usually awake at 4 a.m. to start it then, and some people want that overnight coverage. That overnight coverage is also often used for folks who have very brittle, fragile adrenal insufficiency, folks who've had overnight hypoglycemia, for example. Where I was trained, we tended not to do a bedtime dose unless there was a clear risk factor or reason to do so, because of the adverse effects on metabolism and sleep. But it's a risk-benefit discussion that's really important to have.
We have a couple more. So let's just, when I think that I'm going to read this one off. If hydrocortisone replacement is ideal, is it possible for my child to not have symptoms of replacement? My son immediately developed excessive weight gain, insatiable diet, trouble sleeping, but I was always told it was not from steroids because he was on an appropriate dose. When he is on higher doses, we do not know increased energy. Is ACTH access usually the last one affected?
What a good question. So the questioner makes a few good points talking about weight gain and different vulnerability of different pituitary hormones. I would say the weight gain often occurs at this, at the same time that the operation happened, at the same time that the hormone deficiency was diagnosed, right? Like lots of things are happening at the same time. If I have patients who are curious about excess appetite in relationship to steroid dosing, sometimes what we do is recommend like a very small dose adjustment for a finite period of time, for example, like 2 weeks, 4 weeks, and see, like, does this affect what you observe? Or should we be thinking about other potential reasons for those symptoms?
Okay. I'm going to switch gears for a second.
Yeah. And we have the panel this afternoon, right? So folks should table their adrenal questions.
Absolutely.
If they have more.
Yes, thanks for bringing that up. If we don't get to your question this morning, please join us this afternoon for the general panel, and Shana will be back to answer some of these questions. But if a drug, for example, semaglutide works for normal obesity, how likely is it that it will work for HO? And are such treatments allowed to be prescribed to HO patients?
Yeah, good question. Really good question. So this is what we wonder as we're putting together our clinical trials and our research proposals. I'll say empirically, I mean, you saw the growth chart. I have patients with textbook hypothalamic obesity, like very clear 6 out of 7 hypothalamic damage on that injury scale, who respond beautifully to GLP-1 receptor agonists. Part of that is because the hypothalamus is so important for controlling metabolism, but it isn't the only place. The brain stem, which is in the back of the brain, has GLP-1 receptors. And so maybe one way in which those drugs work that doesn't require the hypothalamus. With respect to safety, we do individualized risk assessment. There are some folks with hypothalamic obesity who have risk with respect to those medicines that give us pause, but we have many who are safe to try it. You saw, though, there's some folks who don't experience benefits, and we know that that's an area we have to think about, like, what do we do for non-responders?
Great, thank you. We're coming up to the close. I have one sort of general question. I think it's a really good question, and I'll share it. How do other doctors hear about these studies? Do individual doctors seek out information and research independently, or are there processes in place to spread information and update best practices?
Wow, that is a great question. So Dr. Alter is the lead on this one, and Amy has helped us host, our neuroendocrine provider conference where we try to give updates. We have professional society conferences, endocrine society, pediatric endocrine society, local endocrine societies where folks come to talk about development. So that's really one way. Many of us also go to the literature when we hear about challenging cases, and we consult each other because we know it's a relatively small community, so we know of our colleagues doing this work. So hopefully all of us are keeping up, but we also hear about it. Craig, I think, mentioned it from our patients who say, hey, gee, I read about this, or I saw about this study, and have you checked it out? Which is a great way for us to learn too.
From your perspective, if a patient, do you appreciate when a patient comes to you with a printout of a study, or, what would you advise patients to do? Maybe if they've seen research, is it appropriate for them to bring it to your attention?
I love that. I think what works best, and Craig is going to give us some awesome advice right at 1:00 about how to have a successful visit. I think what works best, in my experience, but which I hope is true if any of my patients are listening, is that their doctors are open and interested, is to bring those studies to your physician in the spirit of shared inquiry. I think what sometimes happens is folks see it and think there's no single study that's the end all be all, nor does any particular given study guarantee that there will be a same or outcome for that particular patient. So I think bringing it in as a, hey, can we be curious about this together and learn how does it potentially affect, the management plan we put together? I think that works really well. Sometimes folks are so excited and so hopeful about a solution that might be offered by a given paper that they're hopeful that their practitioner will be like, yep, let's do it right away, which may be the right thing, but there may be other considerations. So shared curiosity, I think, usually works really, I hope, well there.
Thank you, Shana. And just a reminder again, everyone can join us at the end of the day for continued QA around these questions. Really appreciate you updating us on the latest research. We're going to take a short break and resume at 12:15. So it's the same link. So if you hop off, just hop back on to this session. Thank you all. Thanks, Shana. We'll see you in a few minutes.